Hi, my name is Caitlin Morissette. I am an emergency medicine and critical care physician at the University of Vermont Health Network. This is work that I completed as a physician builder at the University of Vermont Medical Center. I'll be sharing the work using tools within the electronic health record to document discrete data. This is customizable, computable biomedical knowledge embedded within clinical documentation. As everyone knows, the COVID-19 pandemic was something new and transformative in the world of healthcare. Overnight, everyone around the world was scrambling to try new ways of delivering care, and we haven't stopped. With all of our innovations and models for care delivery, including in my fields of emergency medicine and critical care, we need data that is as agile as our innovations. Data collection and representation within the EHR was built on traditional workflows and fee-for-service revenue models. As we move toward value-based care, we also need data on opportunities. What are the things we might have done? And how do we do less but provide better care? We need our data elements to be designed by the users, changed as needed, and for the results to be tailored to each test of change. At the University of Vermont Medical Center, I partnered with another emergency medicine and critical care physician to design a new process for delivering intensive care consults outside the walls of an ICU. We took care of patients in the emergency room, on hospital wards, and via telehealth. Our care crossed traditional boundaries of departments and even hospitals, and we aim to reduce short ICU stays with high turnover, or to reduce the number of procedural specialists who needed to be called in. So these are largely things that did not happen, and it would have been difficult to measure that in standard EHR data. We were also interested in how decision-making changed over time and some specific details related to mechanical ventilation and medication use. In order to sustain our new service, we needed data to present to institutional leaders, but neither of us wanted to do more paperwork. So we embedded a flowsheet pop-up within our notes and used all of this data for reporting, and then some of it we used to populate our note templates and actually decrease our own documentation burden. Data elements were designed by the people who would be reviewing outcomes and were available as self-service reports to our stakeholders. Through shared review of data, we supported collaborative conversations and were able to demonstrate our value to secure funding for full-time staffing of our new critical care transition service. We adjusted our service and identified future areas of growth based on our reports, and now we're considering how we can build on this to learn more about diagnosis and decision-making. Going forward, we will refine our data elements as our service changes over time. I have built tip sheets on this process to decrease the time it takes for others to deploy this strategy. I would like to work with other ED ICU resuscitation groups to share our data elements and build large databases over time. We will work toward a time where there's enough data available to leverage machine learning tools. This is computable biomedical knowledge designed by physicians and used to make patient care better. Thank you for your time.
Hi, I'm Jerry Osheroff, and my co-authors and I are excited to share with you an opportunity for us to collaborate on advancing CBK-enabled learning health systems. Healthcare today is far from realizing the quintuple aim. That is where we optimize health, reduce costs, satisfy patients and care teams, and achieve equity. Learning health systems are essential for closing this gap. LHSs, whether at the care delivery organization, national or global level, translate healthcare evidence into guidance, put that guidance into action, and use data about the results of those actions to create new evidence, and do all this in a continuously improving cycle. Interoperable CBK is essential to make information flow around this cycle efficient and effective. The ARC Evidence-Based Care Transformation Support, or ACTS initiative, gathered hundreds of stakeholders to produce a future vision, action plan, and concept demonstrations for a knowledge ecosystem that supports CBK-enabled LHS cycles. Since ARC funding ended, the follow-on LHS Collaborative has fostered stakeholder-driven efforts to execute the ACTS action plan, focusing on high-priority targets. The Pain Management Opioid Use LHS Learning Community, or POLIC, is the longest running of these efforts. It includes participants from diverse stakeholder groups working to identify and close pain and opioid management care gaps. The pain and opioid care transformation work that POLIC participants are doing isn't currently leveraging interoperable CBK. However, many POLIC participants are driving progress toward a knowledge ecosystem that is powered by interoperable CBK. This slide has a sampling of these activities, and the link has more details. We're exploring ways these activities could be connected and enhanced to accelerate care transformation and improve LHS function for this target and many others. Although there's interest in connecting these efforts, there doesn't seem to be a robust mechanism to actually make it happen. What's needed is an effort to catalog and cross-fertilize pertinent initiatives. This will need logistic support, which in turn requires funding. Funding is also needed to fill in missing components, support pilot efforts, and scale positive results. We propose that MCBK North America form a work group to explore creating a network of networks that can lead on these next steps. That is to catalog what key stakeholders in different countries are working on, funding, and need help with, and then use this catalog to create a plan for accelerating efforts within and across countries to create a knowledge ecosystem that supports LHSs in broadly achieving the quintuple aim. We're excited to discuss this opportunity with you and collaborate on next steps.
Hello, everyone. My name is Ravi Bhattacharya, and I'm the Principal Knowledge Graph Engineer at Datum. In biomedical domain, we have an abundance of knowledge bases, both structured and unstructured. But one of the problems is the reusability of these knowledge bases beyond their immediate domain is very limited. And main reason being the knowledge sources are not in an interoperable format. So there's a lot of value in being able to adopt FAIR principles for these knowledge bases. There's even more value when you can link these knowledge bases to other related sources. So here we are looking at the clinical trial, knowledge base being linked to drug data and to the side effects data. Similarly, there's even more value when you can actually link your health data or study data to the knowledge graph. So the idea is to start from a baseline knowledge graph constructed out of a set of primitives, which could be your ontologies, controlled vocabularies. So in this case, we are looking at a score's representation of UMLS as a baseline knowledge graph, which can be further augmented with, let's say, clinical trials and curve data set. So here we are linking the mentions of disease and drugs to the UMLS concepts in the knowledge graph. So for this, it also extracts mentions of concepts within free text fields like the inclusion and exclusion criteria. And finally, when it comes to your health data, we can use model like entity event knowledge graph model, which was built by France Inc., where I've consulted and helped with implementation of this model, which involves modeling everything as events around a core entity, which is a patient, and linking any mentions of the biomedical concepts to the knowledge graph. So few advantages of kind of having this kind of model is that you can do information retrieval such as 360 view of patient journey or descriptive analytics of individual and aggregate journeys, and also temporal analytics very easily. And moreover, be able to do something called the knowledge-based data science, where your models can kind of pretend like they actually know a lot about the concepts that they are using in their model. And one advantage of knowledge graph is you can feed in results of analytics back into your knowledge graph, thereby creating a self-learning healthcare loop. So yeah, thank you very much for the opportunity to present here today. Thank you.